Very good. Sometimes it takes a second. So welcome, everyone. I would like to introduce Dr. Dawes to you. She is here to talk about how to make our metabolism healthier and happier.
Okay, well, welcome everybody. I'm Dr. Dawes, and I'm excited to share this talk with you today. Here is a brief outline of what we'll be discussing. So I'm going to talk about what exactly is your metabolism. We will define overweight, obesity, and the metabolic syndrome. We'll talk about the health consequences of metabolic syndrome. I'm going to touch very quickly on other endocrine conditions that can be associated with weight gain and obesity. And then we'll talk a little bit more in detail about the management of metabolic syndrome and the prevention of type 2 diabetes through diet and lifestyle changes, medications, and surgery. So what do you think of when you hear the word metabolism? This is something that I like to start with and I like people to think about because most people usually have an answer that sounds something like, oh, it has to do with how much weight I'm gaining or how much weight I'm losing or the amount of energy I take in. And when you think of those things, you would pretty much be absolutely correct. So metabolism refers to the many chemical processes that occur within all of us to maintain life. It usually does involve the conversion of the foods that we eat into energy and the elimination of waste as well. But it can be thought of as the balance between energy expenditure or the energy that we burn and energy intake or the energy that we take in. If we think about metabolism this way, then we can think of obesity and overweight as an increase in the energy stored as fat that occurs when energy or calorie intake exceeds energy or calorie expenditure. This imbalance usually involves several signals or hormones that allow you to sense the energy status of your body and regulate your hunger level, your energy expenditure, and a lot of other processes that go on in your body. So the most widely used and accepted statistic, I guess, in the medical community for defining overweight and obesity is the body mass index or BMI. Overweight is usually defined by a BMI of 25 to 29.9. Obese is a BMI over 30, and extremely obese is over 35. Over 40 is severely obese or class 3 obesity. However, it's important to keep in mind that BMI is imperfect and it doesn't account for differences in body size and frame depending on your race or your ethnicity. For this reason, the World Health Organization has actually made some lower cutoffs for East and South Asians who tend to be a little bit more petite and maybe have less muscle mass than other ethnicities. So 23 is considered overweight in East and South Asians, and 25 and above is considered obese. I wanted to talk a little bit about the prevalence and the projections of overweight and obesity in the United States. So the prevalence of obesity has actually increased progressively, starting from the year 1988 until the year 2018. The prevalence has increased from 22.9 to 42.4. So there's been a rapid rise in overweight and obesity in the United States, and the prevalence of class 3 or severe obesity, which is defined, as I mentioned before, as a BMI over 40, has increased from 5.7 to 9.2% between 2007 and 2018. Projections from this data suggest that by 2030, at least half of United States adults will be obese and 1/4 will be severely obese. And it's not just a problem in the United States. Since 1980, the prevalence of obesity has doubled in more than 70 countries and has increased in most countries in the world. How can we explain this rapid rise in overweight and obesity? So the simplest explanation is changes in our lifestyle and behaviors. So the lack of regular physical activity or exercise and an increase in caloric intake. So we're eating more than ever, but we are exercising less than ever. But the true explanation is a little bit more complex than that. And the increase in overweight and obesity really has to do with multiple factors. So social norms and values, government and media influences, behavioral settings like your home, your work, your community, and then individual factors like genetics, your individual microbiome, socioeconomic status, and cultural and psychosocial factors. So what hormones or signals are most involved in metabolism and the development of obesity? One of the most important ones is leptin, which is also known as the fullness hormone. So leptin is a hormone that's secreted by fat cells, and it's actually directly proportional to fat mass. So the more fat cells you have in your body, technically, the more leptin you're supposed to have circulating. The leptin itself works in the brain and influences your appetite. So it tells you that you're full. And for this reason, it's believed that the leptin resistance rather than leptin deficiency is what causes obesity, because technically, if you have more fat cells, you should have more leptin and more fullness hormone. But the leptin hormone is increased in obese persons compared with lean persons. Another hormone that's involved is ghrelin, or the hunger hormone. It is produced by the stomach and the small intestine, and it also regulates your appetite. So levels rise right before you eat something to tell you that you're hungry, essentially, and they fall after you've eaten something. Insulin is one of the important ones. It's a hormone that's produced by the beta cells of your pancreas. And what it works to do is promote the absorption of glucose into your liver, fat, and skeletal muscle cells. The glucose is then stored as glucose and fat in your cells. Insulin also inhibits the breakdown of protein, fat, and glucose that is already stored in your cells. GLP-1, or glucagon-like peptide 1, is a hormone that's secreted into the blood by your small intestine in response to food, basically being in your intestines. It increases insulin secretion, increases beta cell mass, inhibits gastric emptying, or basically slows down your digestion, and it decreases food intake. It works on parts of your brain similar to leptin to tell you that you're not as hungry. Lastly, I wanted to mention the adipokines. So these are hormones or molecules that are also secreted directly by fat cells, and they do play a significant role in the development of obesity and its complications. Most of these molecules are inflammatory, and this is why we consider obesity a state of chronic low-grade inflammation. So these inflammatory molecules are a lot of the reason why people with obesity or an overweight, they develop insulin resistance or type 2 diabetes mellitus, and the molecules themselves impair insulin signaling in the body's cells. So what are some of the consequences of overweight and obesity? So obesity leads to hyperinsulinemia, which basically means that there is an abundance of insulin and insulin resistance. So those increased fat cells require more insulin to be secreted from your pancreas, and that increased burden on the pancreas increases the likelihood that your beta cells will fail and you'll develop type 2 diabetes mellitus. Insulin resistance and the increase in those inflammatory fat hormones also lead to blood vessel dysfunction and inflammation. So issues with your veins and your arteries, abnormal cholesterol levels, and high blood pressure, which all increase your risk for cardiovascular disease. So that brings us to metabolic syndrome. So metabolic syndrome is also known as syndrome X, the insulin resistance syndrome, the deadly quartet, or the obesity dyslipidemia syndrome. It is defined or diagnosed based on the presence of any three of the five following things. So abdominal obesity, which is defined as a waist circumference over 40 inches in males and over 35 inches in females. Triglycerides over 150 milligrams per deciliter or treatment for high triglycerides. HDL or good cholesterol level less than 40 in males and less than 50 in females, or being on treatment for low HDL levels. Blood pressure greater than 130 over 85 millimeters mercury, or being on a medication for high blood pressure. And then a fasting plasma glucose over 100, or being on medication for impaired glucose tolerance. The risk factors for metabolic syndrome are age, race, weight, but metabolic syndrome is also associated with postmenopausal status, smoking, low household income, a high carb diet, no alcohol consumption, physical inactivity, and a parental history of metabolic syndrome. Studies have shown that there is a very strong association between metabolic syndrome and the development of type 2 diabetes mellitus. The risk of diabetes also increases with the increasing number of components of metabolic syndrome that a patient has. Some other conditions that are associated with metabolic syndrome are fatty liver disease, liver fibrosis and cirrhosis, chronic kidney disease, PCOS or polycystic ovarian syndrome, and then cognitive decline and dementia in older adults. Now, the other endocrine conditions that can be associated with weight gain are hypothyroidism is the most common. It does contribute to some central adiposity, but I think it's important to note that if you have hypothyroidism and you're being appropriately treated for it, it shouldn't cause any additional weight gain once you are on appropriate treatment. Cushing's syndrome or high cortisol level is a very common reason for weight gain and obesity. This diagram kind of outlines the features of Cushing's syndrome. Most notably, patients have central adiposity with these red stretch marks that are brand new. And usually the weight gain is pretty quick in onset. So it takes 2 or 3 months to gain 50 pounds or 100 pounds or something like that. High cortisol levels are also associated with increased fat deposits in the back, which we unfortunately refer to as buffalo hump, and supraclavicular fat. So that's fat that kind of builds up here in the upper neck. And then lastly, growth hormone deficiency, which is usually associated in adults with who have some kind of pituitary or traumatic brain injury. It can lead to increased central weight gain, so abdominal weight gain. I did want to define prediabetes and type 2 diabetes mellitus. So both are usually diagnosed based on a fasting plasma glucose, a glycated hemoglobin or hemoglobin A1C, or a 2-hour plasma glucose during the 75-gram oral glucose tolerance test. So for a diagnosis of prediabetes, we usually go by a fasting plasma glucose between 100 and 125, a hemoglobin A1C between 5.7 and 6.4, and then a 2-hour plasma glucose during that oral glucose tolerance test that is between 140 and 199. For diagnosis of type 2 diabetes mellitus, we go by a fasting plasma glucose of 126 or greater, an A1C of 6.5 or greater, or a 2-hour plasma glucose during the oral glucose tolerance test over 200 milligrams per deciliter. Important to note that type 2 diabetes can also be diagnosed simply by symptomatic hyperglycemia. So that's an increase in thirst, an increase in urination, weight loss, blurry vision, with a random glucose that is over 200. So you can be diagnosed just with this without any of these other things. And then typically when we see these patients, because they come to the hospital because they're feeling really horribly, we do check a hemoglobin A1C, and it tends to be pretty high because they've gone so long being undiagnosed. So, what are the therapeutic goals in metabolic syndrome and in preventing the onset of type 2 diabetes? The main thing is lifestyle modification. So, we treat on the underlying causes by encouraging weight loss, increasing physical activity, and modifying the diet. And then, if there are cardiovascular risk factors like high blood pressure and cholesterol that persist despite changes in your diet and your lifestyle, we treat those things. So, what kind of a diet should we be following? Time and again, year after year, the best diet has proven to be the Mediterranean diet because it reduces overall mortality and the likelihood of non-fatal myocardial infarction or heart attack when compared to other dietary interventions. So what is important in the Mediterranean diet is that it consists of plenty of fruits, vegetables, whole grains, beans, nuts, and seeds. The primary fat source is olive oil. You are allowed to have fish, poultry, dairy, and eggs in small to moderate amounts. And then rather than having cakes and cookies and all the stuff that we like for dessert, it's recommended that you have fruits for dessert. The important thing is, as you can see in this picture here, everything is fresh and colorful and minimally processed. I kind of just left this in so that you can take a screenshot of your computer or your phone and have a shopping list the next time you go to the grocery store. But the important thing again is that it's mostly vegetables, nuts, beans, lots of whole grains, and then fish and seafood for protein and minimal healthy fats. So avocado, avocado oil, olive oil. In terms of meal planning, this is something that I recommend every day, multiple times a day, and it's something that I follow myself as well. I think it's a pretty easy way to plan your meals, especially lunch and dinner. So you want to imagine that you have a 9 or 10-inch standard dinner plate. And you're splitting it in half, and half of your plate is going to be non-starchy vegetables. So that's broccoli, spinach, peppers, tomatoes, lots of colorful things. The other half of your plate, you want to split it in half again. 1/4 is going to be protein. So fish is good. Turkey and chicken are good. Steak, if you like it, and eggs and other protein foods. And then 1/4 is going to be carbohydrates. But on this My Plate method or diabetes plate method, carbohydrates includes fruits as well as pasta, bread, rice, the other kind of more heavy carbohydrates. And then for something to drink, I usually recommend water more than anything else, but you can have something that's unsweetened or 0 calorie as well. And then when it comes to portion sizes, I think this is really helpful in planning your meals as well. So for vegetables, you want to do 2 handfuls or enough to take up 2 handfuls, but you don't want to overdo it. So you don't want your handfuls to be overflowing. For carbohydrates, so that's both bread, rice, pasta, and your fruits, you want to do a fist size. So you don't want your serving to, or your portion to exceed the size of your fist. For protein, it's a palm full, so not including your fingers, but just the size of your palm. And then for fats, so that's going to include olive oil, avocado, etc. You want to not exceed the size of your thumb. Some other diets that have had benefit are the DASH diet or dietary approaches to stop hypertension. In this diet, your sodium intake is usually limited to 2,400 milligrams. You're allowed to have more dairy than in the Mediterranean diet, but people who have followed this diet have had improvements in their triglycerides, their blood pressure, and their fasting glucose. A high fiber diet consisting of more than 30 grams of fiber a day has shown to reduce weight and blood pressure. And then 8-hour time restricted diet or intermittent fasting, where you still have low carbohydrate, has been shown to reduce all of the components of metabolic syndrome. So improves your triglycerides, your HDL, your glucose tolerance if you follow it for 3 months. So what about exercise? So exercise is the best. It is the best thing that you can do, especially in terms of augmenting weight loss from your diet. So you can diet as much as you want, but if you don't exercise, there's a chance that you might stay exactly the same, even if you are lowering all of those parameters from metabolic syndrome. The other good thing about exercise is in females, it has been shown to more selectively decrease abdominal fat. So you can get like a nice six pack if you're dieting and you're exercising at the same time, and you're female. You want to choose a regimen that you enjoy and also that you can realistically incorporate into your daily routine. So if you're just starting out, you don't want to tell yourself that you're gonna run 5 miles or run for an hour every day. You want to take baby steps, and you want to do something like, okay, well, I know my schedule is really full, but I'm going to make it a point to do 15 minutes of walking or something simple each day. The standard recommendation for the amount of time is 30 minutes of moderate intensity exercise. You want to make sure that you're combining aerobic exercise and resistance training as well, because both together are more effective than either alone in improving your cardiovascular risk parameters. Increasing your level of physical activity also further enhances its beneficial effect. So how much should you be exercising? Any amount is good. The people who are the least active benefit the most from modest increases in their physical activity. In order to lose weight, the goal is to increase energy expenditure. So you want to burn more than you're taking in. The recommendation is increasing the expenditure by 1,000 to 1,200 calories per week, or slightly more than 150 calories per day. And then similar reductions in weight and waist circumference are possible with high and low intensity exercise. So you can run for 20 minutes, or you can take a leisurely walk on the treadmill for an hour and 15 minutes. But as long as you are burning the same amount of calories, you should experience similar reductions in your weight and waist circumference. The only difference is that higher intensity exercise, so running and things that really get your heart pumping, are a little bit better in reducing glucose intolerance. So for a lot of people, walking is the most appropriate or doable form of exercise, and that's okay. In a study of females who had obesity, the combination of diet plus increasing physical activity with short periods of activity into their daily schedule, or incorporating short periods of activity, so walking instead of driving short distances, taking the stairs instead of taking the elevator, was as effective for weight loss as doing a structured aerobic activity like a Zumba class or something like that. So overall, lifestyle interventions, combined diet and exercise, have a more sustained and durable beneficial effect in the prevention of type 2 diabetes mellitus. And the prevention of diabetes mellitus correlates most strongly with weight loss. So what about medical therapies? So for a lot of people, they are not able to sustain lifestyle interventions, or the lifestyle interventions just don't work for them. So they may need to start a medication. For selected patients, especially those who have an A1C of 5.7 to 6.4, which as I mentioned before, we define as prediabetes. We usually start with metformin for diabetes prevention. We usually start with 1 dose a day, and then if it's well tolerated, we go to twice a day. Then there are the new kids on the block, or the GLP-1 receptor agonists. So we talked a little bit about the hormone GLP-1 before, but it's a hormone that's secreted normally into your bloodstream by your intestinal cells. And it binds to multiple different receptors on the surfaces of your cells. So on your pancreatic beta cells, your stomach lining cells, your kidney, lung, heart, skin, immune cells, and the appetite areas of the brain. insulin, like we talked about before. What these medications do is they, like GLP-1, the hormone, stimulate glucose-dependent insulin secretion from the pancreatic beta cells. They slow gastric emptying, so they slow down your digestive process, and they reduce food intake. In patients with type 2 diabetes, mellitus, and obesity, there seems to be an impaired insulin response to GLP-1, and that's why these medications seem to be helpful in preventing type 2 diabetes mellitus. So the medications themselves, the first one is semaglutide, also known as Ozempic, which is FDA approved for the management of type 2 diabetes, and Wegovy, which is FDA approved for weight management. In individuals who have prediabetes and are overweight or obese, these medications, or semaglutide in particular, can help delay or prevent the onset of type 2 diabetes mellitus. In the STEP 1 trial, or the semaglutide treatment effect in people with obesity trial, adults who had prediabetes, so an average BMI of 39 and an average hemoglobin A1C of 5.9%, who were randomly assigned to once weekly semaglutide, 2.4 milligrams for 68 weeks. They had a lower frequency of progression to type 2 diabetes than those who were on placebo. But important to note is that both groups underwent concurrent lifestyle interventions, so both groups were dieting and were exercising. The medication semaglutide has also been shown in studies to have cardiovascular and kidney benefit. So it protects your heart and your blood vessels, and it protects your kidneys. The other medication, which is newer than the semaglutide, is tirzepatide. Mounjaro is FDA approved for the treatment of type 2 diabetes, and Zepbound is FDA approved for weight management. Tirzepatide itself is a dual GLP-1 and GIP receptor agonist. So GIP is a hormone we didn't talk about before, but it is normally secreted with GLP-1, and they work together to increase your glucose-dependent insulin secretion. In the SURMOUNT-2 trial of 938 participants with obesity and type 2 diabetes, the average change in body weight after 72 weeks of the medication was greater for those who took tirzepatide versus those who did not. And patients who were taking tirzepatide 15 milligrams, which is the highest dose, weekly, they lost 20% or more of their body weight. So this medication is especially helpful in managing weight. What about the side effects? So the most commonly reported are nausea, vomiting, diarrhea, and constipation. I would say constipation is a lot more common than diarrhea because it's essentially working to slow down your digestive process. The medications can also cause an increased heart rate. And because of the delayed gastric emptying and the slowing down of your digestive process, if you are going to have an elective surgery where they need to intubate you, we usually recommend that you don't take the medications 7 days prior to that surgery. What are the reasons that we don't use these medications? So pregnancy or pregnant patients can't use these medications. It's really unclear at this point if breastfeeding and nursing patients can use them, and that's mainly because the studies were not done in breastfeeding or nursing patients, so we don't know what effect it could have on breastfeeding or on the infant. If patients have a history of pancreatitis, we typically don't use these medications because, as I mentioned before, what they're supposed to do is increase the glucose-dependent insulin release from your pancreas. So you don't want to do anything that's going to increase inflammation and kind of interfere with that process. And then if patients have a personal or family history of medullary thyroid cancer or multiple endocrine neoplasia type 2, we typically don't use these medications. It's important to note that obesity is a chronic medical condition, and most individuals who start one of these therapies will usually require lifelong therapy. Discontinuation of medical treatment is normally associated with weight regain. So if you stop either of these medications after a long time of taking them, usually, unless you have retrained your body and changed your habits, you do experience weight regain. I lastly wanted to talk a little bit about bariatric surgery. So the indications for the surgical management of severe obesity were first outlined in 1991. And these are those indications. So adults with a body mass index or BMI over 35, regardless of the presence, absence, or severity of comorbidities. So regardless of high blood pressure, high triglycerides, high blood glucose, all of those things. Adults with a BMI between 30 and 34.9 who have type 2 diabetes, and adults with a BMI between 30 and 34.9 who can't achieve substantial or sustainable weight loss or comorbidity improvement by non-surgical means. So these are the procedures that are typically done. So with the gastric bypass, you're essentially just bypassing this first part of the small intestine and attaching the upper part of the stomach to the second part of the small intestine. And with the sleeve gastrectomy, you're kind of cutting off access to the entire fundus of the stomach and reducing the surface area for food. Um, Bariatric surgery does remain the most effective sustained weight loss option for patients who have class 2 or class 3 obesity. For obese diabetic patients who fail lifestyle management and medical therapy, bariatric surgery is usually the most effective treatment, and it can help achieve long-term remission of diabetes. So one study showed that patients who had diabetes at baseline and underwent Roux-en-Y gastric bypass surgery had pretty high rates of remission at 1, 3, 5, and 7 years. So that was 71.2, 69.4, and then 64 and 60% respectively. So it is a pretty durable way to maintain glycemic control. So I wanted to review some of my key points. So diet and exercise have a more sustained benefit overall on reducing cardiovascular risk and the prevention of the onset of type 2 diabetes than medications do. And the goal of dietary therapy is to reduce your total number of calories and so we want to try to avoid focusing on a specific nutrient like keto diet or something like that, and rather want you to focus on choosing healthy foods overall. Exercise is the best. Regular exercise reduces overall risk of mortality for most individuals. The mortality risk reduction also does not depend on the type of activity that you're doing. So any kind of movement is better than no movement at all. There is a strong inverse relationship between exercise and the risk of coronary disease, cardiac events, and cardiovascular death. Exercise also provides modest protection against several kinds of cancers like breast, intestinal, bladder, kidney, lung, stomach, esophageal, prostate, endometrial. Weight-bearing exercise is good for you. It's associated with an increase in bone mineral density in both males and females. It is also associated with improved cognitive function. It helps you sleep better. It makes you less stressed out. It reduces anxiety, reduces the risk for depression, and higher energy expenditure through exercise usually leads to a greater improvement in measures of both physical and psychological quality of life. So exercise is very, very good for you. Some people, unfortunately, can't achieve weight loss and risk reduction with diet and exercise alone, so they are good candidates for the injectable GLP-1 receptor agonist medications or the combined GLP-GIP receptor agonist. And some people with severe obesity do need bariatric surgery, which then significantly reduces not just their weight, but cardiovascular risk and morbidity and mortality from obesity-related complications. So thank you for your attention.
Thank you so much. That was awesome. There was just so much great information. You see the hands all chatting up there. I was trying to see if Emily Brown was still on the call. Some people had asked some questions about the Mediterranean diet and the DASH diet, and how eating the lower oh my gosh, I cannot speak today. Inflammatory foods are beneficial. And she put a nice little comment in there. Emily was actually one of our speakers last year, and she came in and talked about the blue zone areas.
Mhm.
And about the diets with that. So that was something great. So a lot of information and a lot of great tips that you gave us. Some of the questions that we're getting are, we'll go with the best one first. Is wine part of the Mediterranean diet?
So, I mean, I guess it is, but like, all good things, you want to kind of enjoy it in moderation. I think most people probably notice too that one of the things that increases your risk for metabolic syndrome is like complete lack of alcohol consumption. So I would say that like alcohol consumption, probably red wine, more than anything else in moderation is probably healthy. You could probably consider it healthy, but of course, drink responsibly and in moderation. Don't take that to mean that, Dr. Doss said that I should drink a couple of glasses of wine every day.
I think one of the things we always need to talk about is that each person has their individual needs and their individual health. So that's really important that this is great information, but for their own personal health, they need to be talking one-to-one with the registered dietitian, with the physician, so that they're getting the plan that's best for them. One of the questions that we have here is if someone is on that DASH diet and they're taking metformin, can they do the intermittent fasting, or is there going to be some sort of contraindications with that?
There shouldn't be. Metformin is a medication that all it really does, or its mechanism of action, is that it increases your body's sensitivity to the insulin that you're already making. And that's why we use it more typically in patients who have type 2 diabetes rather than type 1 diabetes, because in type 2 diabetes, that's essentially what you want. You want your body to respond appropriately to the insulin that it's still making. So there really shouldn't be any contraindication or really any reason why you can't do intermittent fasting and take metformin at the same time. I know that they say take metformin with food. So if you're doing 8 hours in the day that you're eating, you can always take one of the doses in the morning when you start eating and one in the afternoon or evening when you're about to be done. And most of that is also because it can have some unpleasant GI effects. So if you take it with food, you're less likely to have those GI effects. So there shouldn't be any reason why you can't take metformin if you're doing intermittent fasting.
Are you seeing in general overall a benefit from people when they start, yes, looking at that Mediterranean diet, but really looking for those anti-inflammatory foods and spices? There's all these things out there now saying, take the turmeric, take this. Are you seeing that when you're taking those supplements or finding foods that it's giving them enough added benefit to make some changes?
I think that's a really good question because honestly, there haven't been enough scientific studies done to show that they truly benefit or harm you in any way in particular. But I am all for, natural ways of kind of helping yourself and helping your body and your cells kind of do the things they need to do. So if you are taking some of those supplements or using some of those spices and you don't feel like it's really harming you or you think it's helping, I'm all for that. It's just that I can't confidently say, based on this study or this article done in this medical paper that, you should absolutely be on like berberine or you should absolutely be on turmeric because it has proven benefit, because I don't know that. I haven't seen that in any studies, but I do think that if you feel it's helping you and not harming you, I'm all for you continuing it.
I think one of the things I have heard a number of our dietitians say as I've gone around and talked is don't just start taking handfuls of supplements unless you're talking to somebody, because your body may not need that. So if you are looking to do that, that again is a conversation you want to have with your physician and a registered dietitian possibly to make sure you're getting that good balance. And Emily in her post in our chat said that no, if you're following Dr. Dawes's recommendations and you're putting more plant-based food on your plate, you are getting a lot of the anti-inflammatory Mediterranean diet things.
Exactly.
But there's a difference between putting food and putting pills in your body, and you always want to make sure you're having someone kind of help guide you and have
Yeah.
the good information. The other thing we have in the chat is Joan. There was a question about, you are wonderful, but you are on Morton Plant's campus, so sometimes that's a little far for people to go, but you are seeing patients who are 18 and over. So if anyone is interested, the information is on the screen right there. But say you're in another area, Joan put in a couple of other physicians who might be in the other areas, or you can go to 1-800-BayCare and look up one of the docs, and they can talk to you and help you find a doctor who will be closer to you to meet your needs also, if they all can't get to you. Lots of great information. I'm sliding through the chat here. Moderation is key, as that is so true. There, as soon as you say no, you can never have this again, what is the one thing you want? So it's better to try and flip that brain and think of the positive things. Okay, yes, I'm not going to say no, I can't have this, but look, yes, I can have this, that, and the other thing. So that's wonderful.
Yeah, and that is a conversation I actually have like plenty of times, multiple times during the day, because I definitely believe in, not saying absolutely no to any one food or any one thing, because I too am human. And if I tell myself I'm not going to have, cookies or something for the next 30 days, then I'm going to go home and I'm immediately going to have cookies. So I know that urge to like want to have the things that you're not supposed to have. So I definitely believe in everything in moderation, and I will never tell you like to stop eating something completely or stop doing something completely.
When we have our friends from psychology and behavioral health, and they always talk about that when you go in that deprivation mindset, that's the first thing you want, and it actually creates certain chemical reactions in your brain.
Yeah,
And we want to be looking for the positives, because then we're creating a better hormonal flow in our body, and we can maybe reduce some of that cortisol so we don't have all of those issues.
exactly.
So there's some more physicians in there. We have a whiskey and bourbon drinker who's wondering if they're allowed to have that also, in moderation, as they're doing things.
I mean, I will say that like clear liquors, they are less likely to be full of sugar, so they're probably better than, colored liquors. But again, drink responsibly. I'm not telling you that you should go have whiskey or bourbon every day. Just everything in moderation.
So there's a bunch of questions about the metformin on here. Basically, what is my starting doses that can be there? And then what else? Is there any side effects to that more than what you talked about, some gastric things? And can you take ROSUVAS,
Oh,
rosuvastatin?
rosuvastatin.
Yes.
Mm-hmm.
Um, does that help red yeast rice and cinnamon? Are all those things helpful? Can you take that with the metformin?
So there is no reason why you can't take metformin with a statin. They actually probably together are beneficial or more beneficial for you than either alone. Metformin, so it depends, the dosing kind of depends on what you're using it for. So if we are using it for prevention of the onset of type 2 diabetes, we usually go anywhere from 750 to 850. We start with once a day, and then you usually take that dose every night with dinner or right before dinner. And if you tolerate it well, meaning you don't have any like gas, bloating, diarrhea, things like that, then you add the other pill of 750 or 850 in the morning, and we would have you on 750 or 850 twice a day, and then recheck all of your, glycemic parameters in a couple of months. For the treatment of type 2 diabetes, we usually start with 500 once a day, then go to 500 twice a day, and then go to 1,000 twice a day. So the typical highest dose you see patients on who have type 2 diabetes is 1,000 milligrams twice a day, so before breakfast and before dinner. The rosuvastatin is for cholesterol lowering. And so that's why they're kind of working in different ways. And so if you are on metformin, which is going to improve your blood glucose, and a statin, which is going to improve your cholesterol, you're already kind of working to decrease your risk for metabolic syndrome and cardiovascular disease. So they definitely work fine together. And then with the cinnamon and the red yeast rice, again, I don't think that there's any problem with them. It's just that there haven't been enough studies or, articles done to really show that they're truly beneficial or they're truly harmful. So if you feel like they're helping you, and you're not getting any weird side effects from them, then it's okay by me to continue taking them.
I think it's always important to know that a lot of those supplements and red rice and stuff, they're not always FDA checked. So make sure the
Exactly.
quality of the products that you're getting are what you think you're getting, because there can be some changes with that, or some issues with that if you're not getting it from a reputable place.
Exactly.
Are there any blood tests for or stuff you can do for your hormones to check to make sure your hormone levels are normal? And what age do we see this onset of this metabolic syndrome?
So it sort of depends. So, like most of the things we talked about, each person is different. Each person's medical history and family history is different. There are certain like age cutoffs that we use, but again, that depends on your family history. So I would say that typically over the age of 35, if someone is overweight or obese, we do usually check, your lipid panel, so your cholesterol, your A1C, to make sure everything looks good and you're not at increased risk for developing type 2 diabetes, or to make sure that you don't have high cholesterol. In general, over the age of 45, we kind of start checking everyone and making sure that their glycemic parameters look good or their metabolic syndrome parameters look good. And then there was another part of that question I'm forgetting. Could you repeat the
I put a
question?
couple together, so let me think
Oh,
where
the
I was at.
hormones. I think the
Yes, the
hormone
hormones. If
levels.
there's any blood work that I should be looking for my hormones.
So I usually do not check hormones kind of willy-nilly. If you have a compelling reason to check a certain hormone, that is when I am more likely to check that hormone for you. For example, a lot of people have, sudden onset of unexplained fatigue. They're sleeping more than usual. They're suddenly gaining weight. Their hair is falling out or their skin is dry. And those constellation or that constellation of symptoms tells me that maybe there's something wrong with your thyroid. And so then I would check your thyroid hormones. But on a day-to-day basis, if you're not experiencing anything weird, I would not kind of just go and ask someone to check your hormone levels, because it's kind of, the information that you get and what you do with that information. So let's say you do check all these hormones and then you get the results and they're kind of normal and you don't know what to do with that information. And that's kind of the same thing for me. Like if I see a bunch of normal hormones, then I wonder like, well, why was this checked in the first place? So you want to make sure that you're checking particular things for a reason. If you have a reason to check them, like fatigue or dizziness or something like that, then that's when I kind of advocate for checking hormone levels. But I don't normally, even tell my friends like, hey, you should go get your hormone levels checked and then you can come be my patient. If there's a reason to check them, absolutely yes. But typically I don't check, a full panel of hormones for no reason.
I know we are over time, and we want to thank you all for being here. I want to ask, if you have to go, please go, but we'll have this recorded if you want to catch the last question or so that we're going to answer. If outside of thyroid cancer, if you're a hyperthyroid, what are some of the other negative effects of the thyroid?
The negative effects of the thyroid, like in hyper or hypo or both?
Hypo, it said, I believe. Let me go back and
Okay.
hypothyroid.
Okay,
with
so
you.
hypothyroid just means that your body is not making enough thyroid hormone. The issue with that is thyroid hormone goes to all of the cells or all of the other cells in your body. So it goes to your heart, it goes to your lungs, it goes to your stomach, it goes to your intestine, and it helps carry out a lot of metabolic processes. So if you're hypothyroid, then we kind of associate that with like this state of hypoactivity. So everything's kind of slowed down when you're hypothyroid. Um, that is why, like I said, when you experience certain symptoms or like a constellation of symptoms that seem like you may have an issue with your thyroid, that's when we usually check your thyroid hormone levels. Again, like I mentioned during the talk, if you are found to be hypothyroid and we replace your thyroid hormone and you're on appropriate treatment and your labs show that your TSH and your free T4 are within normal limits, that shouldn't cause additional problems. Once you're on treatment, most patients kind of feel like, they're back to themselves. But if you go untreated, obviously those issues will get worse and worse, and you'll feel more and more tired with time, and you'll have more hair fall and drier skin and things like that.
Well, that was a ton of wonderful information. I know we are over time, and we're thankful for everyone who was able to be on the call with us. I will see what other questions we have in the chat and see if I can get them answered to put into our follow-up email. But we want to thank you all for being here. Emily also put some great information in the chat. I will try and capture that information and share that in the follow-up email that will have the PDF of the presentation. So thank you all for being here. We look forward to hopefully seeing you again next month. Dr. Dawes, thank you for sharing your, wonderful talents with us and hopefully giving people some information. And if you are having questions, reach out, make sure you're calling a physician and getting that conversation started so that you can take care of your health and that you can have better well-being and, go on that path.
Thank you,
Thank you,
everyone.
everyone. Bye-bye.